And I think it's time for a short wrap up, for a short summary. So Mark van der Boogaard talked about sedation, pain assessment, and delirium management. And I think it's very important that you know tools how to assess pain in critical ill patients. Mark mentions the CPOT or BPS. You can learn this on the ICU, and the physicians and nurses will show it to you. Assess frequently the pain of patients. The main goal of the critical care is comfort of the patient. Some patients need only light sedation, others require deep sedation, depending on the illness and all the stress and so on. Sedation does not mean sleep. Patients do not have a sleep structure like you have a usual sleep, but sedation induce coma. Nevertheless, you can talk to patients as if they would be awake. A lot of patients remember experience when they were in deep sedation. For assessing sedation, you use the RASS score, Richmond Agitation Sedation Score, and you use it also frequently, and you can use the level of sedation or agitation in these patients. Sometimes we use daily wake-up calls when patients, you stop sedation, let them wake up. And I think this can be a job for you, standing at the bedside, informing patients when they wake up. They will be surprised where they are. Then you can inform them you're on the ICU and we take care for you. Delirium frequently happens to critical care patients. Delirium is a serious side effect of critical care, and you can use also assessment like the CAM ICU or ICDSC to assess patients for delirium. There is no drug that can prevent from delirium, but you can use nursing bundles like frequent reorientation, talk to the patient, invite the family, offer hearing and vision aids classes, mobilize patients, try to use a usual day and night rhythm so that they can reorientate again and come through this delirium. It's very important. Delirious patients often make frightening experiences, and you at the bedside are very important to explain all these experiences and to ensure that they are safe in a safe environment. Katerina talked about drugs in the ICU, frequent drugs. We use insulin, for example. Insulin is often used to reduce hyperglycemia, especially after sepsis, for example. When you administer insulin, side effect of insulin is often hypoglycemia, and this is a critical situation. Patients start sweating, nausea, hypotension, and so on, and then you have to measure the blood sugar in the patient. Usual administration line is intravenous lines, and when you administer insulin via a pump, of course you have to measure it frequently and to adapt the delivery rate. It's very good if you are using protocols for administration and also for restart in insulin. Corticosteroids are often used in septic shock, for example, or also in COVID-19, for example. They induce hyperglycemia, and then you are using insulin again. And there are different versions of corticosteroids depending on the half-life of them. And the physicians will tell you how to administer them. Diuretics are also used to control fluids in critical ill patients, and they have several side effects like changing electrolytes, for example, or leading to hypotension. And again, you have to control patients for this. This can be a great help for patients. This can help them for surviving critical illness. But of course, you have to be very careful. And the good thing is the nurses and physicians will show you what you can do when you are insecure, or even if you are doing mistakes, you are never alone. They all will help you, and they will appreciate your help when you're helping them with critical ill, with dealing with COVID-19. So I hope this was a good introduction for you to other aspects of critical care, and continue with your learning, and thank you for your help.